Welcome back to the Deep Dive. Today we are tackling a disease that it often feels like a relic of history, but it's still this colossal global health crisis.
It really is.
We're talking about tuberculosis or TB.
That's right. And we're not just, revisiting old stories of consumption. We're going to use this stack of clinical sources to really build a kind of study guide.
A study guide, I like that.
Yeah, our mission here is to walk you through it step by step, from the really surprising epidemiology all the way to the tricky parts, like drug resistance and managing side effects.
Okay, so a structured understanding of TB as a clinical puzzle.
Exactly.
And when you start with the epidemiology, the first fact is it's just so crucial for setting the stage.
It really is.
We think of infectious diseases, and you picture getting sick right away.
Right.
But TB, it's different. The sources show that when you're first infected, only a tiny minority, 5%?
Just 5% of people, they're the ones who actually develop primary TB disease.
So what happens to everyone else, the other 95%?
That statistic is, it's the cornerstone of how we manage TB. The vast majority, that 95%, they develop what we call latent TB infection, LTBI.
And latent means what exactly? They're not sick.
Not sick at all. They're asymptomatic. They're not contagious. The bacteria is basically walled off by their immune system.
Okay, so 95% have this dormant infection. And I see here there's a 5% lifetime risk of it, waking up, of reactivation.
Exactly. And that 5% risk is what defines the entire public health dilemma.
Because if most people just stay latent forever, you might ask, why bother screening and treating them?
Because that 5% risk is very real. And when you're talking about billions of people, that translates into millions of potential active contagious cases. You have to find that pool of latent infection before someone's immune system falters.
So treating latent TB is really just prevention.
It is prevention, full stop.
Okay, let's unpack that core difference then. Latent versus active.
So, like we said, latent TB, or LTBI, the infection is dormant, no symptoms, and critically, you are not contagious.
And active.
Active TB is when the bacteria has breached those immune barriers, it's multiplying, it's causing damage, and that's when you get the classic symptoms and you become infectious to others.
And when we look at who's most likely to make that jump from latent to active, the screening efforts focus on really specific groups. Why these people?
It all comes down to a compromised immune system or a very high initial exposure to the bacteria. So we focused intensely on household contacts of an active TB case.
Makes sense. High exposure risk.
Exactly. Then we target people with failing immune systems. So HIV-infected individuals or anyone who is biologically suppressed, maybe from drugs for an autoimmune disease.
And there's one on the list that isn't an infection, silicosis.
Yes, silicosis. It's a lung disease you get from inhaling silica dust. And for some reason, the lung environment it creates, that fibrosis, it seems to make it much, much easier for latent TB to reactivate.
So before we get to finding active disease, what's the plan for that huge 95% pool, the LTBI patients?
Well, first, you have to be absolutely sure they don't have active disease. Once you've ruled that out, the treatment for LTBI is, it's relatively straightforward.
Simpler than for active TB?
Much. It's isoniazid, along with pyridoxine, for 6 months. It's a shorter, less complex regimen because the bacterial load is so low and it's all contained.
Okay, that brings us to detection. The source material talks about two main screening tests for latent infection, the Mantoux and the IGRA.
Right. The Mantoux test, or the TST, is the classic one, the old school one. You inject a tiny amount of PPD, that's purified protein derivative, under the skin.
And then you wait.
You wait for 48 to 72 hours. And the key thing, and this is so important, is that you're measuring the induration.
The bump.
The firm, palpable bump. Not the erythema, not the redness around it. That's a super common mistake.
But the TST gets complicated, right? Because of the BCG vaccine.
Exactly. This is where the newer test, the IGRA, really shines.
So tell me about that.
Well, the BCG vaccine is given to children all over the world in countries where TB is common, and it can cause a false positive on the TST because the vaccine uses similar antigens.
So if you've had a BCG vaccine, the TST is basically unreliable.
Pretty much. That's where the IGRA comes in. It's a blood test, the interferon gamma release assay. It tests for an immune response to TB antigens that are not in the BCG vaccine.
So it's more specific.
Much more. It gives you a true negative and avoids that false positive you get from the TST in someone who's had the BCG shot.
That feels like a really high yield point for anyone studying this. BCG history means you should lean on the IGRA.
Absolutely.
Okay, so let's say screening points towards active disease. What are the definitive tests? How do you prove it?
To confirm it, you need proof. So we need 3 early morning sputum samples.
Why early morning?
That's when the bacteria are most concentrated. They're sent for an AFB smear, acid-fast bacilli smear. But, and you should know this, about 35% of active TB cases can still have a negative smear.
So a negative smear doesn't rule it out.
Not at all. We also use the older, slower LJ medium culture and now, much more commonly, PCR for rapid molecular detection.
And before a patient even takes the first pill, there's this whole list of baseline tests, pre-TX baseline tests. This looks like a safety checklist.
That's exactly what it is. It's a mandatory safety net. Before you start someone on this powerful multi-drug regimen, you need baseline liver function tests, urate levels, their HBsAg and anti-HIV status, and, this is critical, a baseline eye exam.
For visual acuity.
For baseline visual acuity. These tests aren't for diagnosis. They're all for monitoring the pretty severe toxicity these drugs can cause down the line.
Okay. That systematic approach leads us to what TB actually looks like. Let's start with the classic picture, pulmonary TB.
Right, the classic presentation. We're talking about pulmonary symptoms that just drag on for weeks or even months. A chronic cough, sputum, sometimes coughing up blood hemoptysis, and chest pain.
And systemic symptoms, too.
Oh, yeah. Systemically, it's defined by these constitutional symptoms, what we call LOA, loss of appetite, which leads to weight loss, and a persistent, usually low-grade fever.
But the real lesson here, I think, is that TB is a master of disguise. Extrapulmonary TB, EPTB, it can look like dozens of other diseases.
It's the ultimate shapeshifter, absolutely. EPTB can show up anywhere, which is why you always have to have a high index of suspicion.
So where does it go?
One of the more common forms is tuberculous lymphadenitis. You might have heard the old term scrofula. It often shows up as chronically swollen lymph nodes, usually in the neck.
And it doesn't spare the bones or the brain.
No. The skeletal involvement is significant. The most famous is Pott's disease. That's TB of the spine. It can cause the vertebrae to collapse.
Wow.
Yeah. And of course, it can invade the nervous system, leading to TB meningitis, or TBM, which is one of the most lethal and difficult forms to treat.
It really hammers home why the sources say you have to look beyond the chest x-ray. It can also hit the gut and the GU tract.
Correct. Gastrointestinal TB can look like peritonitis or massive abdominal lymph nodes, mimicking other GI diseases. In the genitourinary system, you can get things like TB epididymitis if a patient have a chronic, what we call sterile pyuria.
Pus in the urine, but no bacteria grows on a normal culture.
Exactly. You have to consider GU TB.
All of this just underlines the diagnostic challenge. Okay, let's get into the treatment. It's intensive, and it's all built around control, right? Because of the risk of resistance.
Precisely. The global standard is DOTS, directly observed treatment, short course. This literally means a healthcare worker watches the patient swallow every single dose of their medicine.
Every dose. That's a huge commitment.
It's incredibly labor-intensive, but it's essential for adherence, for getting a cure, and for preventing drug resistance.
So what's the standard regimen for a regular, uncomplicated lung case?
It's a 6-month commitment. The first 2 months, the intensive phase, is HRZE. Then you have a 4-month continuation phase of just HR.
HRZE, so that's isoniazid, rifampicin, pyrazinamide, and ethambutol.
Correct. All 4 for 2 months, then you drop the last 2 and continue with just isoniazid and rifampicin for 4 more months.
And for those really complicated extrapulmonary forms like TB in the brain or bones,
the duration gets longer. Significantly longer. For major EPTB like meningitis or bone and joint TB, treatment is extended to 12 months.
So a full year.
A full year. It's still 2 months of HRZE, but followed by 10 months of just HR. You need that extra time to make sure you kill the bacteria in those hard-to-reach places.
Let's zoom in on those 4 first-line drugs, H, R, Z, and E. The list of side effects is pretty daunting. Let's start with isoniazid, or H.
Well, isoniazid is probably our most powerful bactericidal drug against TB. But yeah, the side effects are significant. Rash, hepatitis, about a 35% risk there, and peripheral neuropathy.
And that neuropathy is the reason for a mandatory caution, right? There's something you have to give with it.
Non-negotiable. Isoniazid messes with the body's use of pyridoxine, which is vitamin B6. This causes nerve damage, so you must prescribe pyridoxine supplementation alongside it to prevent that.
Got it. Okay, next up is rifampicin. This is the one that changes your body fluid.
It is. Side effects include about a 15% risk of hepatitis, GI upset, low platelets. But the big cautions are 1, hypersensitivity reactions, and 2, you have to counsel the patient that it turns all their body fluids harmless but Pretty startling red-orange color.
So tears, sweat, urine, everything.
Everything. And a huge clinical point. It's a powerful enzyme inducer, so it makes things like oral contraceptives and some heart medications much less effective.
That's a massive drug interaction to watch out for. Then we have pyrazinamide, Z. This one looks like the heavy hitter for the liver.
It has the highest risk of all four, yeah. Around an 80% risk for hepatitis. It also commonly causes joint pain and can trigger a gout attack because it raises urate levels.
So do you treat the high urate levels?
Only if they're symptomatic. If the patient has gout, you treat the gout. But you don't need to treat the high number on the lab report if the patient feels fine.
And finally, ethambutol, E. This one links directly back to that baseline eye exam.
That's right. Ethambutol can cause retrobulbar neuritis, which is inflammation of the optic nerve. It can decrease visual acuity, often starting in one eye.
So the caution is?
The caution is critical. You must have that baseline visual acuity test before starting. And you have to monitor their vision closely during treatment. If the patient reports any change in vision or color perception, you stop the drug and get an ophthalmology consult immediately.
The level of vigilance required is just, wow. But even with all that, you're going to face complications. Let's talk about the two biggest ones, drug resistance and liver toxicity.
Drug resistance is the single biggest threat to getting rid of TB globally. We define it based on those first-line drugs. MDR TB, multi-drug resistant PB, means the bacteria is resistant to at least rifampicin and isoniazid.
Our two most powerful drugs.
Exactly. The prevalence is still low, thankfully, under 1%.
And then there's XDR TB. This is the one we really fear.
Extensively drug-resistant TB, XDR. That's MDR TB plus resistance to a fluoroquinolone plus resistance to 2 of the 3 injectable second-line drugs. It's a nightmare to treat, but it's extremely rare, less than 0.1%.
Let's pivot to the more immediate safety issue. Hepatotoxicity, liver damage. Since 3 of the 4 drugs can cause it, the sources have a very clear action plan. When do you have to stop treatment?
You discontinue treatment immediately if the patient develops symptoms or if their lab work shows their ALT, a key liver enzyme, goes above 3 times the upper limit of normal.
Or bilirubin goes up.
Or bilirubin goes over 2 times the upper limit. Either of those, and you stop everything.
But you don't just assume it's the TB drugs, right? What's the first step?
Critical first step. You have to rule out other causes of acute hepatitis. Check for alcohol use, check for hepatitis B and C. Once those are ruled out, you switch the patient to a temporary, safer regimen with less hepatotoxic drugs.
And then comes the really complex part. Once the liver starts to recover, you don't just restart all 4 drugs. There's a sequential re-challenge. Why?
You do it slowly and sequentially to figure out which specific drug was the culprit. You need to identify the antagonist so you can potentially avoid it for good.
And what's that specific sequence?
Once the ALT is back to normal, you re-challenge them in a specific order. You start with rifampicin. If that's tolerated, you add isoniazid.
And pyrazinamide is saved for dead last.
Always dead last.
Why?
Right.
Even if it means delaying getting back to the full-strength regimen.
Because, like we said, it is by far the most hepatotoxic agent with that 80% risk. You reintroduce the drugs from least likely culprit to most likely. If the patient's liver flares up again right after you add pyrazinamide, well, you found your problem.
This was a really rapid but high-yield journey. We've gone from that huge split between latent and active infection through BCG screening, the systemic reach of EPTB, and these really critical side effect protocols.
And we've highlighted why treating LTBI is so important for prevention, the need for baseline eye exams for ethambutol, and that non-negotiable pyridoxine supplementation with isoniazid.
Thinking about prevention one last time, the BCG vaccine. What's the big picture takeaway on its effectiveness?
You know, its effectiveness against regular pulmonary TB is all over the map, anywhere from 0 to 80%. But it is very effective at preventing the most devastating forms of the disease in children, especially miliary TB and TB meningitis.
And a quick note on pregnancy.
Right. BCG itself is contraindicated in pregnancy, but the 4 first-line drugs we talked about and the fluoroquinolones are generally considered safe to use during pregnancy.
That detailed, sequential re-challenge for liver injury is fascinating. It's a perfect example of applying critical thinking when the pressure is on.
It really is. It forces you to think about all the different factors at play. I mean, what if you miss something? What if you forget to rule out, say, chronic alcohol use or an active hepatitis B infection, and you mistakenly blame one of the TB drugs? What kind of cascade of events does that set off? It's why this kind of clinical knowledge has to be really understood, not just memorized like a checklist. It's something for you to mull over as you try to integrate all this into your own clinical framework.